Good morning, everyone. Welcome to Echo Diabetes in the time of COVID-19. Thank you so much for joining this session. We're grateful for the unrestricted educational grant that we received from Novo Nordisk and Pfizer Inc. that makes this program possible. Our goal is to address the urgent needs of patients with type 1 and type 2 diabetes who require complex diabetes treatment in the time of COVID-19 and beyond. We want to empower primary care providers and clinics to safely and effectively manage underserved patients who do not have access to routine specialty care. Here at Stanford, we're partnering with Project ECHO and other sites across the United States on this series. Project ECHO, known for Extension for Community Healthcare Outcomes, is a globally recognized hub and spoke outreach model developed out of the University of New Mexico. This model is aimed at reducing disparities and improving health outcomes in patients who otherwise lack routine specialty care. Using video conferencing to conduct Zoom-based clinics led by multidisciplinary faculty from academic medical centers and community providers. Project ECHO provides community clinicians with education, case-based learning, expertise they need to treat patients within their own community. Our presentation agenda will be a lecture followed by one case presentation, and we'll address some of the pre-submitted questions our audience members submitted during registration. We'll have a short Q&A session after the lecture and after each case presentation. For those of you who have not participated in ECHO's session, please submit any clarifying questions and or recommendations in the Q&A box during the case. In terms of a bit of housekeeping for the session, please use Q&A features in the Zoom to submit specific to the topic or the presentation. The chat box would like to be used for communicating among our attendees to share best practice resources. We'll try our best to address all of your questions submitted through registration and the chat. However, if we're unable to get to your question today, please register for a future session and submit your questions again. This webinar is being recorded, and the lecture portion of this webinar will be available a few weeks on our website. The case presentation from today will not be included on our webinar. Our web development team is working to build a resource library on our COVID-19 website where session materials may be found. After the webinar ends, you'll be asked and emailed an evaluation that we'd be grateful for you to complete so we can continue to improve our program and better address your needs. Please note that none of our faculty have relevant financial relationships with commercial interest to disclose. For those of you who have not participated in ECHO program before, we encourage you to submit case presentations, and that can be found here on this link, or also we'll type that into the chat box for you to submit a case. We're very excited about our series. We have 16 weekly series with a variety of topics, and feel free to drop in or invite other colleagues to drop in on any of these relevant topics that might be in your clinic. And we're fortunate to have a national faculty team from over 12 ECHO programs, over 13 states. And I now would like to introduce them. And I'm going to stop sharing my screen. I'm going to start with our Stanford staff team, and I'll start with Linda.
Hi, I'm Linda Baer, and I'm the Director of Education for this program. We're so glad you could join us.
And Marissa.
Hi, I'm Marissa Town. I'm the Program Manager.
Christine.
Hi, I'm Christine Weir. I'm the Program Coordinator.
Great. And now moving on to our faculty team here at Stanford, Magdalena.
Hi, this is Magdalena Ford. I'm a nurse practitioner with Stanford Endocrinology, and I'm one of the faculty members.
Hey, Corey.
Hi, my name's Corey Hood. I'm a staff psychologist and professor here at Stanford.
Rayhan.
Hey there, guys. I'm Rayhan. I've had type 1 for 30 years. I'm an adult and pediatric endocrinologist over at Stanford.
And David.
David Maas, pediatric endocrine chief.
And in California, Kelly.
Hello, My name is Kelly Close, and I'm the founder of diatribe.org. I've been asked by the team at Stanford, where I've been so lucky to receive so much care, to help provide any answers or input on patient-related questions.
Moving over to Florida, Eleni.
Hi, I'm Eleni Sheehan. I'm a family nurse practitioner and diabetes educator at the University of Florida Endocrinology.
Great. And also in Florida, Ashby.
Hi everyone, I'm Ashby Walker. I'm a medical sociologist at the University of Florida, and we're thrilled to be here today.
And then also from Florida, Sarah. Okay, I think I lost her. Moving over to early morning Hawaii, Dan.
I'm Dan Saltman. I'm an associate clinical professor at the University of Hawaii and the director of the Hawaii Learning Groups, a Project ECHO partner.
And to Iowa, Dave. Oh, we don't have your audio, Dave. All right. Well, we'll come back to David later for his case presentation from Siouxland Community Health Center. And then Louisiana, do we have Dragana on? Okay, and moving over to Maine, Erwin.
Hi, I'm Erwin Brodsky. I'm an endocrinologist at Maine Medical Partners Endocrinology and Diabetes Center and a scientist at the Maine Medical Center Research Institute.
And to Massachusetts, Samar. Your audio is not working, Samar.
All right, sorry about that. I'm Samar.
Great.
I'm an adult endocrinologist and I work at the Joslin Diabetes Center in Boston.
And to Nebraska, Leslie.
Hi, I'm Leslie Island. I'm an adult endocrinologist at the University of Nebraska Medical Center in Omaha.
And to New Jersey, Mary.
Hi everyone, I'm Mary Bridgman. I'm a clinical professor at the School of Pharmacy at Rutgers University and a clinical pharmacist at Robert Wood Johnson University Hospital.
And to New Mexico and the ECHO Institute, Matt.
Hi there, Matt Bouchonville, adult endocrinology here at University of New Mexico and ECHO Institute.
And to New York, Marissa.
Hi, I'm an adult endocrinologist at SUNY Upstate Medical University in Syracuse, New York.
And to Washington, D.C., Nicole.
Hello, yes, my name is Nicole Earhart. I'm an adult endocrinologist here at GW in Washington, D.C.
And also in D.C., Rohit.
Hi, this is Rohit Jain. I'm an adult endocrinologist at George Washington University in D.C.
Great. Well, thank you so much to our faculty.
We have one more faculty member.
Oh, great. Who do I miss?
Marina, if you would introduce yourself.
Marina.
Sure. I'm Marina Bassina from Stanford University, California, adult endocrinology.
All right. So we're going to move on to our first didactic, and I'm going to be talking about leveraging telehealth and remote monitoring to support patients with diabetes. Many of you in your clinics and organizations have probably been joining into webinars on telehealth, and I'm going to try to focus this particularly on diabetes in the primary care setting and to kind of overcome any obstacles to get you to start going with that. I don't have any financial interest to disclose. At the end of this activity, I'd like you to be able to prioritize essential components of a telehealth encounter for a patient with diabetes in the primary care setting, to identify available tools and resources for diabetes remote monitoring, and identify and address barriers to implementing telehealth and remote monitoring for patients with diabetes in your practice. And once again, as a reminder, if you have questions, please type them into the question box and chat. If you have resources that are related to some of the topics I'm talking with, please feel free to type them into the chat box and share with the community. We have a diverse group on this webinar today, international and national. And in terms of within the U.S., there's no standardization of definitions with telehealth services across the states. So what I'm going to talk about here is definitions based on CMS or Medicare. And today's session is really going to focus on the telehealth visit. And there's some other components of virtual types of service, virtual check-ins, e-visits, and telephone service that I'm going to touch upon to put things in context. And really want to call everyone's attention to the Center for Connected Health Policy. They have resources per state. Each state, Medicaid, has different regulations and policies regarding virtual services. So if you haven't been here yet, recommend doing so, and they also have great webinars. So the 1135 waiver that was issued almost 2 months ago really opened up the floodgates to telehealth and also to diabetes. So there was relaxation of HIPAA requirements of how we conduct telehealth. There's elimination of Medicare restrictions on licensing for telehealth and eliminating geographic restrictions on originating states. And then there's the waiver of face-to-face encounter requirements for FQHCs. There's the waiver of limitations around virtual telephone communications prior to or after a visit, and also for established patients versus new patients. And perhaps most importantly is the reimbursement for providers for telephone visits and telehealth synchronous video visits can now be billed at the rate of an office visit. And Medicaid interpretation and policies are, as I mentioned before, vary per state. And changes are happening on a daily to weekly basis. So it's really important to recheck policies and be in touch with those within your organization. Now, this is more of a reference slide. I'm not going to dive too much into this. And today we're going to focus mostly on the Medicare telehealth visits. And once again, these conducting them through video or over the phone can be replacing in-person visits. There's also virtual check-ins. A new policy change is that this can be used for new patients, not just established patients. And also this also opens up sites beyond rural clinics. And then there's the e-visits, and then there's also remote monitoring services, which is not considered telehealth. There's now coverage for new and established patients for this. I want to call attention to continuous glucose monitoring. We're going to have a separate session on this in terms of how you can bill for other teleservices. And depending on the CGM manufacturer, they have different guidance on coding and billing. And once again, more to come in the near future on this in our series. And many people with diabetes have comorbidities, and so there's also opportunity to integrate other remote monitoring services such as blood pressure, pulse ox into your flow. This is just an example of some of the CPT codes. And once again, I'm not going to dive too much into this. In terms of diabetes self-management training, or DSMT, it's now been clarified that rural healthcare centers and FQHCs are able to do one-on-one DSMT by any healthcare practitioner who's practicing within their scope, and the billing code is referenced there. For non-rural healthcare clinics and non-FQHCs and non-hospitals, this is the list of healthcare professionals who are able to conduct DSMT via telehealth. We're still seeking clarification if RNs and pharmacists are able to do so, but we believe the intention of the regulations is yes, but as of right now, there's not confirmation that that's possible. And phone visits audio are only permissible when video and audio are not possible. I also want to call your attention to a mini-series being conducted by the ECHO Institute on implementing telemedicine and telehealth services in your clinic. The series launched this past Monday, and the sessions are listed here coming up on May 27th and June 1st. You can use this link to register for the sessions or go to the ECHO Institute website. Now moving on to the diabetes telehealth visit and kind of how to get started. I'm going to walk through some of these components of scheduling, check-ins, logistics, prioritizing patients' top priorities, social history, reviewing the medications and refills, diabetes data, the physical exam, labs, and wrapping it up. So most important, you got to schedule patients. And so some people might be already scheduled as in-person visit. And so you need to either convert them to telehealth and or schedule a follow-up for telehealth. So contact and counsel your patients how the visit will work. Use your staff to do that. Confirm backup contacts, provide patients with phone numbers of how to get in touch with the provider. Provide instructions to the patients on how to show up. If the patients can't show up, then the visit stops there. Many patients are not accustomed to technology. Some have flip phones, and so try to avoid mumbo jumbo of technology. And then provide some backup. So if people are going to be signing on through a platform, and something happens, give them a phone number of how they can reach the clinic or the provider to conduct the visit over the phone. Encourage patients to come prepared. Ask them to have a list of 3 key questions they want to address during the visit. And then if you're able to, try to screen for social history and social determinants of health prior to the visit so you all can be prepared to address the complexity of any issues that come up and probably are going to require more than 15 to 30 minutes of time to help the patient trouble solve. And to call attention to the digital divide and that continues to be an access issue to broadband throughout the United States and other countries. And then even for people who have hotspots, Wi-Fi connection continues to be spotty in places throughout the country. So some people have to rely on landlines, and there's also some great resources for conducting telephone visits through the American AAFP, which is referenced here. So once patients check in, once again, we want them to be able to show up in your clinic, trying to establish a workflow of how you want to check patients in and notifying the providers. The diabetes data in clinics, some of you might be downloading data. Some of you might be having patients bring in a logbook, figure out what you're going to do with that data. For those of you who have patients who have data where they can upload to the cloud instead of download, if possible, try to use your MA or other staff members to transfer the diabetes data into the EHR prior to the visit. It could be done a day before, maybe 30 minutes prior. For medications, review the diabetes medications with the patients, ask specific questions, ensure there's adequate refills, ask about financial insecurity, ask about their copays, ask if they're using home delivery.
Kelly just sent me a link.
And social determinants of health. Integrate routine check-in questions into your telehealth visit. In terms of the platform, it does not have to be fancy. You can use Zoom. Once again, with 1135 waiver, there's been relaxation of requirements for the platform. It does not have to integrate into your EHR. And the allocation of time for a visit for telehealth visits, usually they're a little bit less than a face-to-face encounter. But with diabetes and the complexity, the team approach is critical. And so how can you incorporate other staff members like social workers, behavioral health specialists into your visit, and not just the provider? And so coming up with ways to think about that. And then once you start the visit, prioritizing the patient's top priorities. So ask the patient if he or she has questions, and let's make sure you have time to address those questions. Address the elephant in the room, address COVID-19, any concerns that the patient might have. For telehealth, consent that they're okay doing a telehealth visit, and also set expectations of the visit that it might not be what you might be accustomed to be able to accomplish for an in-person visit. One of the most critical parts of for a diabetes encounter is the social history and really demonstrating empathy and reviewing the social determinants of health. You can find out a lot about diabetes management by asking about their daily routine and schedule. So, ask specific times. What time do you have meals? What times are you dosing your insulin or taking your diabetes medication? Ask about exercise. When are they doing it? Are they doing it? How often are they doing it? Ask about, are they getting outside? Ask about changes in work schedule. They might not be willing to disclose that they're unemployed, but when you ask about work, that might come up. Ask about their sleep and their sleep hygiene. Review who's in the household, who's supporting them, who's working with them. You can review their last PHQ-9 and assess for depression and also assess for diabetes distress. And we'll have a whole other session in this series on diabetes distress and depression. Medication and refills. Review the medications and don't trust what's in the EHR. Ask them what they are doing, not what is prescribed. Confirm with them. We want to make sure patients have at least 30 days supply, but ideally 90 days. And so ask how much they have left. Specifically ask about each type of insulin, right? So if people are on basal and bolus insulin, do you have insulin? If they say yes, well, we need to clarify what type of insulins that they have. Ask about if they have copays. Many pharmaceutical companies are now having copay assistance for the high deductible plans, and counsel about home medication delivery if they're not using it. Offer additional care coordination and support if it's available. And we'll have another session on this as well in terms of sick day management, but try to review the sick day management plan and ask if they know what to do if they get sick and how to make their medication dose adjustments. And there's some great resources here, reference on the right from Diatribe. And reviewing the nutrition, when you're going over the daily schedule, ask about the times of each meal. Ask about how much are they eating. Don't assume that they're giving insulin with each meal. Ask about how many times a day are they not able to give their insulin. Are they giving their insulin before or after? And then ask about food insecurity and availability of healthy foods. And in your clinics, if you have additional resources to support patients with healthy foods or other community stakeholders, it's a great time to connect them. And reviewing the diabetes data, we're going to have 2 separate sessions on this. And if you don't have uploads or downloads, the majority of the visit can still be conducted. So this should not prevent you from conducting a telehealth visit for diabetes. But if they do have data that's uploaded and you're using a video conference, you can use share screen feature and look over their patterns with them. You can ask them to tell them about what patterns they're noticing. And you can have them look at their meter and read out values. Or you can have them look at, if they're keeping a daily log, you can have them look at their daily log, tell you, take a picture, hold the daily log up to the screen. And if they're not checking their blood sugar, then explore barriers to what's preventing them. And once again, on June 3rd and June 10th, we're going to have additional sessions on this where we'll be exploring CGM and beyond A1C targets. And we'll be also looking at platforms to help support remote monitoring in your clinics. So what are reasonable blood glucose targets during the time of COVID? They're really essentially the same targets as non-COVID, but these are not easy or realistic within the current delivery of care system, where 30 to 40% of patients with type 1 and type 2 diabetes have A1Cs over 9% or what is being defined as HEDIS as poor control. So without COVID, diabetes management was tough enough, and now we're in COVID, and we know that this group is especially high risk. So the physical exam, it's going to be limited, but there's also caveats that you can obtain over the phone. Measurements, you can ask them your recent weight. Do you have a scale at home? Or when was the last time you weighed yourself? If they have a home blood pressure cuff, you can ask them to do that. If they're injecting insulin, you can ask about lipohypertrophy, so fatty tissue around the sites of the injections. Are there any issues there? Is there any redness? If they're having any feet issues, you can ask them about their feet, any change in sensation, have them do a home foot exam. Labs, so you can ask when the last labs were done, trying to figure out which labs are essential. Is that A1C really needed to make dose adjustments? Those of you might be aware there are home A1C kits. But for those of you who have patients on continuous glucose monitors, using the glucose management indicator or the GMI provides you an estimate of the glucose, and a CGM provides you much more than the A1C. And this is an example that we'll get more into in upcoming sessions, but you can get a sense of what's going on times of the day when patients are having hypoglycemia or hyperglycemia. And so hopefully CGM is something you can take advantage of. And then wrapping up the visit, prioritize the top priorities that you recognize that to address. Maximum 3. You can use the ask method. You can use action planning. You can use the teach back closing the loop method. So for example, just to be sure I was clear, how will you pick up your insulin prescription? So ask them to tell you. And then scheduling follow-up. Don't let that follow-up fall through the cracks. Have your staff go ahead and schedule patients as soon as the visit's over, or call them back and ask them questions. And I'm going to stop there. I'm going to open it up for questions that were submitted. And Marissa?
Yes. So we had a lot of questions related to if the content will be posted and how to get CME, and we did post those answers in the chat, but just so everyone knows, you will be receiving an email after this, and you also can go to the website, which is diabetescovid.stanford.edu. And we've posted that in the chat a few times, and you should have gotten it in an email. And on there will be the recording of the webinar. We're hoping to have it in a few weeks. And as well, you'll also be able to get the PowerPoint presentation slides. And as far as answered questions, it looks like we had a lot of other questions, and I apologize for the use of jargon. We did not anticipate having such an international audience for this, but I would like to see if anyone that is on our team wanted to go ahead and answer some of those questions. Maybe Rayhan, do you want to start with some of the answers that you replied to?
Absolutely. So we definitely had a good number of questions about home metrics and what can be done at home versus what do we need the clinic for. So one question related to blood pressure readings that might be taken at home. Certainly some information is better than no information, but there is a lot of good evidence that serial home measurements can provide some reliable measurements. And we also worry about things like white coat hypertension, which is not as much an issue if one is measuring at home. So certainly having access to those sorts of measurements is helpful. And then there was another question related to whether these changes in reimbursement and allowances, how long will those continue for? The answer is nobody knows at this stage. But as long as we have the current COVID issue, this will seem to be a continued change to the policies. So at least in the intermediate term, I would expect that to continue. And somebody asked what was hemoglobin A1C measurement. It's the average glucose measured over the last several months. And I think those were the ones I had replied to.
Yeah, that's great. And there were a few other questions, like we mentioned earlier, we won't be able to get to all of them. So please send us an email or ping us. If we haven't already told you, we'll reply to you directly. And one of the other questions I wanted to see if Matt, if you wouldn't mind replying. It looks like you replied about someone asked if people with diabetes are more likely to get an infection even if their blood glucose levels are controlled.
You bet. That is a great question and kind of a challenging one to answer. I think I actually have a couple of slides on that, and I'm happy to review those now, or maybe when we get to Nick or Marissa, any preference on that?
Yeah, we can. We'll come back to that on the submitted questions. Thanks so much, Matt.
Great. Thank you for the question.
And then let me just take a look at these live questions. And so, this is another question sort of about home metrics for challenges in countries where there isn't a lot of infrastructure for obtaining and recording data. I don't know, Nick, if you have any advice on that, or if you want to answer that later.
Sure. Yeah, and it's not just international. It's here in the U.S. too, where patients aren't checking their blood sugar, and you don't have data, and you have to make the best. So asking about symptoms: are you peeing more? Are you more thirsty? Is your pee more sticky? So there's other things we can do to try to assess for degree of hyperglycemia and trying to adjust medications. And then there was also another question that came in the chat box asking about this program in terms of target audience and pharmacists. Yes, we have a pharmacist on our hub team, and Mary, you can talk a little bit more on their specific topics. So please look through the series information, and you can see what might be more relevant to you.
Okay, and I think at this time, we're going to stop with the Q&A and move on to our case presentation.
I think that's a great note to transition from this case presentation to some of the pre-submitted questions. We had over 50 questions that were submitted prior to registration. And we've gone through them kind of by theme and the most submitted, and we're just going to talk about them right now. I'm going to share my screen, and then if you have additional questions, please continue to type in. And if you have additional questions you want us to address next week when you register, as a reminder, please submit a question. So our first question: are patients with diabetes more prone to getting COVID-19? Matt?
Yes, I'll take it from here. Thank you, Nick. This is a great, important question. And the short story, and it's a challenging one to answer. The short story is that there hasn't been clear evidence thus far that having diabetes increases the likelihood of getting an infection. I think there's some confusion around this question because there is more evidence to suggest that if your patient with diabetes gets COVID, then there may be a higher risk of complications, including death, related to the COVID. But having diabetes doesn't necessarily just increase the risk of getting COVID. And I think big picture-wise, though, what do we counsel our patients on with respect to this question? I think whether you have diabetes or not, the virus is very contagious. So we're still going to be recommending the same things for everyone: mask use, social distancing, hand washing, and so forth. But it's particularly important for those with diabetes because if they do get COVID, the risk of complications is greater. And Nick, you might be sharing some recent data with us soon, suggesting maybe the risk is even greater with type 1 diabetes, and there's than with type 2. And then there's some suggestion that glycemic control might affect the severity of symptoms of COVID-19 as well. This is a nice resource here for your patients with diabetes. It's the ADA website, American Diabetes Association. I like this website. There's a hot link at the bottom of the slide because they're continuously updating these answers as new evidence emerges. But questions for patients like, are people with diabetes more likely to get COVID-19? If they do get COVID-19, is there a higher risk of complications? So this is useful to refer your patients to. Thank you.
Great, thank you, Matt. And then as you referenced, hot off the press this morning that you all might start to get questions about that came out of data released from the UK and the NHS there, showing that likelihood of dying in the hospital, I'll highlight that, in the hospital, that patients with type 1 diabetes are 3.5 times higher risk of dying in the hospital, and patients with type 2 are 2 times the risk. And the biggest risk factor among patients with diabetes remains age, with those being over 40 years old having the highest likelihood of dying in the hospital, and no reports of death in the hospital were reported in patients less than 20 years of age. Once again, this speaks to death in the hospital, and so it might be more loaded also in terms of how diabetes is being managed in the hospital. But here are the related links. So this should not be interpreted that people with diabetes are 3.5 times more likely to die. This is based off of deaths that happened in the hospital. Another question that came in, should we be more concerned about DKA during COVID-19? Rehan, do you want to talk?
Absolutely. So guys, we got the question asking about diabetic ketoacidosis. Diabetic ketoacidosis, or DKA, is a state of near absolute insulinopenia, meaning in your body there is very, very low levels of insulin approaching zero. And unfortunately, there is this bad balance that occurs where counter-regulatory hormones, things that increase blood sugar like epinephrine, glucagon, growth hormone, lead to activation of hormone-sensitive lipases, which break down fat, and this generates ketone bodies as a product of fat metabolism. This creates acidosis and can be very damaging because acidemia, as we know, is not a condition well tolerated by the bodies. So there is this big question, and this will lead into our question about ACEs and ARBs, about ACE2. So COVID has these spike proteins on the outside which interact with a protein called ACE2 on the surface of the cells of your body. It's a balancing act. ACE2 itself is actually helpful. It decreases the incidence of lung injury, inflammation. So it is helpful, but it is also the target of the infection, how the infection gets into cells. So there's this question of whether ACE2 is good or bad. We do know that ACE2 is expressed on islet cells, the cells that make insulin. So what that means is potentially the virus may cause inflammation and damage, which was previously demonstrated with SARS, the prior COVID type infection. In theory, this can worsen the insulin production state. In other words, somebody who makes very little insulin may make even less if they have the infection. Plus, you have an increase in all these hormones that increase glucose. So we know that the Italian groups have observed frequent cases of severe DKA for patients that were hospitalized, and perhaps this sort of bench stuff plays in to the pathophysiology of that. And Nick, if I could get the next slide. The other thing that we wanted to highlight is that deep Kussmaul breathing, which is a characteristic of DKA, people trying to blow off as much CO2 as they can. in order to compensate for the acidosis that might be confused for pulmonary function issues that you may associate with COVID. So you really need to evaluate when people come in with diabetes, which is the bigger factor here. Are they suffering from an infection, or could this be ketoacidosis? You want to ask questions about polyuria, polydipsia, weight loss, decreased energy, vomiting, and one can do a urine analysis to quickly screen for DKA and eventually get some blood work if it's suggestive.
Great. Another question related. For patients with diabetes and hypertension, are there particular medications that should be avoided, such as ACE inhibitors or ARBs?
Sure.
Mary, I'm going to pass this over to you.
Yeah, thank you. And I think this is an excellent question, and I can kind of piggyback onto some of Rayhan's comments. Again, as a pharmacist, I sort of see the world through the lens of pharmacology. So I think the question becomes, what's the pharmacologic plausibility behind this concern? We know COVID-19 essentially hijacks the renin-angiotensin-aldosterone system. The virus uses the angiotensin-converting enzyme 2, that so-called ACE2 receptor, for entry into the target cells. There was a key study that was published by Zhao and colleagues back in February that described that the virus is able to use the ACE2 proteins as the entry receptor, and that ACE2 is probably the cell receptor really through which SARS-CoV-2 enters cells. And then there was a commentary in the Lancet Respiratory Journal describing and hypothesizing the relationship between increased ACE2 in patients with type 1 or type 2 diabetes, or patients who are receiving an ACE or an ARB, or in individuals with hypertension, and suggesting that ACE2 upregulation might facilitate infection and potentially increase susceptibility or risk of severe disease. And then we know the media got a hold of that, and it sort of spread like wildfire. And I think there was really panic amongst patients and providers originally. We did have previous evidence from animal models and that ACE inhibitors and ARBs increase ACE2 expression, coupled with sort of this unfolding information about virus infectivity, leading to this hypothesis that ACE2 upregulation might facilitate infectivity and increase susceptibility to infection or severe disease. So then the question becomes, how do we respond to patient questions and concerns given the present evidence? And really, if we take a look at some of the recommendations, based on current expert opinion, patients who are prescribed ACE inhibitors or angiotensin receptor blockers should really not stop therapy. They should not change therapy unless advised to do so by their provider because of another compelling indication to disrupt or interrupt treatment. I would really welcome others' thoughts and experience with this, but I think that's really consistent with the recommendations from essentially every major national and international medicine society at this point in time. That goes for patients who are at risk for, who are being evaluated for, or who are diagnosed with COVID-19. So in short, I think really the evidence at present suggests benefits of continuing ACE inhibitors outweighs theoretical risks. We don't have evidence to suggest harm, and actually there's even some potential emerging evidence that these agents may be beneficial with regard to COVID-19 outcomes. Over the past week or so, we've seen some observational studies coming out that suggest ACE or ARB use in patients hospitalized with COVID-19 receiving these drugs for hypertension actually have similar or lower mortality rates compared with those who aren't taking these drugs of either class.
Thank you so much, Mary. That's once again been a big topic of discussion and going around. For more additional information, there are some links here. And once again, these slides will be shared on our website as well. Moving to our last pre-submitted question, how depression may affect or worsen diabetes control during social distancing and stay-at-home orders. Corey, do you want to address this? And just a plug, we're going to have a whole additional session on diabetes, distress, and depression.
Sure. Thanks, Nick. I'll go through this quickly. There's a lot of text here, but keep in mind that you can go back and look at the slides. So just real quickly, before COVID, we know that depression and diabetes distress affect diabetes management. It really happens in two ways. One is on the mind. So the person feels less motivated, less interested, and then more so on the body or on the actions, that makes the person less likely to be active and do tasks. So in the presence of depression and distress, we know that they create problems for people managing diabetes, type 1, type 2, all types of diabetes. But in the COVID era, and there's data that's starting to trickle in that shows that people are reporting more worries and more distress related to diabetes, and also kind of related to this broader picture of COVID. So the reasons that depression and distress might be exacerbated in the COVID era are because people are less physically active. When they're less active, that can lead to more depression. Their eating patterns are different, and they may have less motivation to change them. I think something that we don't notice or don't think of so much is that there are fewer daily routine changes and distractions. So someone who is distressed or stressed, that can usually help them ignore some of those. But when it's in your face all of the time, it can be hard to ignore some of those things. And then people are more concerned, people with diabetes, even if the data is shown to them that they're not at higher risk, many of them still believe they're at higher risk for COVID. And so they're planning to even delay further some of the resumption of activities. So, and then their networks have changed. I think the case is a great example where they receive support may be gone. And so I think that what this leads me to suggest is that we monitor depression frequently. We can do that through questions that are posed to them. There are a lot of validated surveys that have been done remotely with people. But also if you notice any significant changes, one of the first areas to suspect it might be depression and distress, and to try and connect them to behavioral health at the first sign. Don't delay or don't wait. And then, and I think that we have some resources on the website for places that they can go and where you can find more information.